up.
While Dr. Gabbay is loading his presentation, if I can introduce him. Dr. Gabbay is the Chief Scientific and Medical Officer of the American Diabetes Association, the global authority on diabetes, and he leads ADA's efforts to drive discovery within the world of diabetes research, care, and prevention. He has extensive affairs in interventions targeting primary care and quality improvement with grants from the NIH, NIDDK, and the Agency for Healthcare Research and Quality, along with the Center of Medicare and Medicaid. We all know that he has leadership roles within national and international societies and has also appeared in the popular press, including the New York Times, CNN, and so on. He currently currently serving as Chief Scientific and Medical Officer at the ADA. He has been the Chief Medical Officer and Senior Vice President at Joslin previously, along with being an Associate Professor at Harvard Medical University. He obtained his bachelor's at McGill and then a PhD in biochemistry from the University of Wisconsin, moved on to do medical school from Brooklyn School of Medicine, and then a residency at New York Hospital Cornell and a fellowship at a joint Joslin Beth Israel and Brigham and Women's Hospital program at Harvard. He's a visiting scientist at MIT and a professor of medicine at Pennsylvania State University College of Medicine. Dr. Gabbay, clearly you have 1 foot in the diabetes and medicine world and 1 foot in the innovation, engineering, and the MIT world. So welcome, and we are very excited to have you here with us today.
Well, thank you so much, and really appreciate the invitation to meet with you all. And what I'm going to talk about today is really the ADA standards of care. And my sense is that it's a mixed group of different levels of expertise. So I'll try to have something for everybody. And apologies that I could not be there with you all. And I look forward to the day where that is possible. And it's nice to see some friends and colleagues in the audience as well. So I am going to start with this. So this looks a little different than what I'm used to. So I'm assuming that you see me making a change in slides.
Yes, the slides are advanced.
Good. So I'm going to start with a little polling question, which you can answer in the chat. And I want to sort of get a sense of my audience. So have you read through the 2022 ADA Standards of Medical Care? And please be honest. I'm trying to get a sense of my audience. So feel free. There are no wrong answers. Throw whatever you can into the chat. For those of you that are sitting next to a computer.
You can always say that you went through the abbreviated version. Right?
Yeah, right. And there's really no wrong answer here. So in fact, I will tell you that there's some yeses, some nos, some of it. Good. So there are a good number of people that have looked at it either partially or not really looked at it. And that's helpful because that's sort of the whole point of me being here today is that many of you may not have had the opportunity. And to be honest, before I came to the ADA, I was probably one of those, like some of the answers, skimmed through what's new and sort of went from there. So let me, since the backgrounds vary of the group, let me start by telling you a little bit about the process of what we do with the standards of care and how this develops. And so this is a yearly publication. I would say the most widely recognized guidelines for diabetes care in the world. It starts, as you might imagine, with an exhaustive literature review of everything new since the last year, what new studies may have influenced the recommendations that are there. And so after that careful review of the literature and assignment of different sections to various group members, we have an amazing interdisciplinary professional practice committee, and pleased that Diana Isaacs was an integral part of that group. These individuals are at the top of their game in various fields of diabetes. They review, discuss, debate, and sometimes argue all of the evidence to come up with the recommendations and ultimately come to consensus. That consensus is then brought to our senior leadership, our board of directors, approved and then released. And the funding, I'll just mention, is completely independent. There's no corporate funding whatsoever for this. This is really out of ADA funds itself. And obviously, we're very careful about conflict of interest, and more than 50% of the individuals are required to have no conflicts. So what I'm going to try to do, this is a 200 some page document, and there's a lot in it, and I encourage you to take a look, and I'll tell you some resources at the end. But what I'm going to do is really focus on what's new. And then in the discussion at the end, certainly glad to talk about other aspects that I'm not covering here. But if you stand back and look at what is in the standards and what's new, they really fall into four themes. Um, it is around screening, and I'll talk about that. Continued journey around individualized care, both for type 2 and type 1 diabetes. There is a lot of new information on comorbidities, and I will highlight that. And then finally, around glycemic assessment and technology, a rapidly moving field where there are a number of new things in the standards. So what I'll do is walk you through each of these. I'll use a case along the way to help illustrate some points, and then we'll leave hopefully lots of time for discussion to get into aspects that are of greatest interest to you all. So first of all, what is new in screening? And the first thing around screening for diabetes is that any individual 18 or over that is overweight or obese has risk factors for diabetes should be screened for diabetes. And as you know, the usual screening, fasting glucose, 2-hour postprandial, or I think what's becoming the most common form now is really an A1C. The big news is the second point, which you may not have gotten to everybody, and that is that if you don't fulfill those first criteria of being overweight or obese over age teen and risk factors, everybody in the U.S. should be screened for diabetes at age 35, and that used to be 45. So it's a big drop, and that's part because there's so many undiagnosed individuals with diabetes. They're developing diabetes at a younger age. There also are a repeat of old recommendations, but I'll just remind you of those. Anyone, a child 6 months or younger, one should really consider specific causes of diabetes. If there is an autosomal dominant pattern, one should be considering a genetic testing for MODY. So that is in terms of ages of screening. And then if the individual screens negative, they should be rescreened at least every 3 years, unless they develop symptoms or new risk factors for diabetes. And then the other point where there's been some controversy has been around point of care testing. As a blanket statement, we don't recommend point of care testing for the diagnosis of diabetes, for prediabetes. Certainly very helpful in the clinical management of diabetes. And that's because not all of the point of care testing, in fact, many of them, most of them are not approved for use for diagnosis. And so really the laboratory A1C is sort of the gold standard here. And feel free to put any questions, comments in the chat. I'm not sure what your tradition is to do questions as we go, or we'll just handle them all at the end.
Handle them all at the end. We don't want to interrupt your flow.
Okay, fair enough. All right, thank you. All right, great. So this is also new and new recommendations, and this is really around preconception and pregnancy and screening for diabetes, and largely around screening for the existence of prediabetes, which we now realize again is quite common. So individuals with risk factors for diabetes should be screened at preconception counseling for the pre-existing presence of diabetes. Similarly, if they at the first prenatal visit, they should also be screened for the presence of pre-existing diabetes. This is separate from the usual screening aspect that we do for gestational diabetes at 24 to 28 weeks. So really screening individuals, screening women twice or potentially three times preconception counseling early in their pregnancy and then for gestational diabetes. And depending on the population you serve that may be at particularly high risk to begin with, it may be a good idea to screen all women in this category. Okay, so that is a screening around pregnancy and preconception, and then the last part of new screening information is around type 1 diabetes. And I'll allude to this in a little while when we talk about management and individualized care. But there was a wonderful consensus report done by ADA and our European colleagues, EASD, around diagnosis management of type 1 diabetes. And part of what was detailed there is a reminder to clinicians and, particularly for our primary care colleagues, when to be thinking about type 1 diabetes, because I suspect many of you have seen, as I have, patients coming in that were diagnosed with diabetes, placed on an oral agent, but they actually had type 1 diabetes. And we now know, of course, that this can happen at any age. More common, age less than 35, so that should clue the clinician in. BMI less than 25, diabetic ketoacidosis, of course, as another criteria. Um, so thinking about type 1 diabetes, and I think in my population, I would say literally any thinner person that is diagnosed with diabetes, you need to think about the presence of type 1 uh, and rule that out in some manner. The other recommendation that is new and has some more detail behind it in the document is around first degree relatives. So, first of all, they should be made aware that they're at increased risk for developing type 1 diabetes. And in terms of screening, the typical recommendations have been in the setting of clinical trial studies like TrialNet. Um, I think the biggest part of that is the appropriate counseling that is available with the screening for autoantibodies. Um, as you know, there is a new therapy under review at the FDA, teplizumab, for delaying onset and delaying need for insulin for individuals with type 1 diabetes. And so there's a renewed interest potentially once this becomes available to screen many more individuals for the presence of type 1 or at least of autoantibodies. And the important recommendation here is that that should be done only in the setting where there's appropriate counseling available. So that is what's new on screening. So now we're going to move to comorbidities. I'm sorry, we're going to move to individualized care. And this has really been, as you all know, a journey in the management of diabetes where we've really over the last 10 to 15 years, I would say, continue to individualize care. And so some new recommendations about that I will share now. So the high level here is really for each individual in terms of their management, pharmacological management of type 2 diabetes. It's really a consideration of 5 factors, and based on that, making decisions on therapy. The first, and really in some ways the most important because it dictates the first step, are the presence of comorbidities, and particularly atherosclerotic cardiovascular disease, heart failure, or chronic kidney disease. As I'll show you in the algorithm in a moment, if one has any of those, they follow a different pathway, so to speak. So first is, do they have a comorbidity, one of those 3? Then it's consideration of hypoglycemia and which agents are less likely or do not cause hypoglycemia. Um, the the area that's becoming increasingly important, and as we are starting to think about the 2023 standards of care, is around weight. And so weight considerations. And so that's the third thing to be thinking about. Um, Access and cost to the individual, and therefore their access to medication is an important factor. And I would argue, unfortunately, in this country and literally around the world for a variety of different reasons. And so there are recommendations around that. And then something newer added is really consideration of efficacy, in that not all agents are equally efficacious, and therefore individuals with higher A1Cs need agents that are more potent to be able to bring them down to goal. So this is the high level view, and I will now share a complicated diagram, I will admit, that I'll break down for you that tries to put everything in one page, particularly again for our primary care colleagues that can use this as a pocket card. So I will walk you through this and blow up various sections of it, but I'll call your attention to and that there are really sort of 2 halves here, and what's on the left, which is really about the comorbidities, and then what's on the right, the other factors. So I will again now blow up this diagram, but want you to think of it conceptually, what it looks like in the big picture. So this is that left side of the diagram. Again, the left side of the diagram here blown up. And you can see here for starts that the recommendations, and this is newer, is that of course one takes a variety of patient factors into account in individualizing care. But really the important piece here is if individuals have one of these 3 comorbidities, um, one should be using these agents that we'll talk about in a moment, regardless of A1C, no matter whether they are at goal or not, and regardless of the presence of metformin. So these can be used independent of metformin, and therefore sometimes they may be the first line agents. So let me show you the 3 conditions here. And so in the far left here, it's atherosclerotic cardiovascular disease or high risk. And you see that the choice is either GLP1 or SGLT2, based on the studies that have shown real efficacy for those individuals in terms of reducing morbidity and mortality. And what's new is an inclusion of using both together, because there is data suggesting that both in combination are additive in their effects. And so that's what's new. Um, Now, if someone has heart failure, then really the preference is around SGLT2 as therapy. Again, regardless of glycemic control, regardless of the presence of metformin. And in the CKD condition, there are really 2, there's another fork point, and I'm going to blow up that side of the diagram in the next figure here so you can see that. So really here, it's a matter of the presence of a significant albuminuria or not. If not, the two agents essentially have equal billing, SGLT2 and GLP1. If there is significant albuminuria, the preference is really towards SGLT2. So let me try to have you synthesize this information and think about this with a case. And so Edward's a patient that is 45. He comes to see you because he's checked his blood glucose with his mother's glucometer. And he's had a morning level in the 200s, A1C of 9.1. He has a history of coronary artery disease. Appropriately is on statin, an ACE inhibitor, and aspirin, and his BMI is elevated at 36. Sorry, this is a screen is small on my side here. So what is the first line therapy? And this is the audience participation part. So throw it into the chat. Throw in what you think. So what would the first line therapy be? Would you start glyburide? Would you start an SGLT2? Would you start metformin, a GLP1, or would you start some form of combination therapy? So I'll give you a moment to think about what the first line therapy is, and please throw it into the chat. And again, no wrong answers here. So please, these are all potentially reasonable therapies. It looks like we have some votes for aggressive therapy. Number 5, it's really catching on here. Number 5 seems to be dominating. Okay, so this is interesting because in many audiences that I present this to, 5 is there, but it is not as common and almost unanimous as I am seeing it here. So great. Uh, so let's think about here where this gentleman falls into. Edward has atherosclerotic cardiovascular disease, so he's on the left side of the diagram. And the idea here is using an SGLT2 or GLP1 agent, regardless of use of metformin. And I suspect many of you chose combination therapy because either one of those agents alone is unlikely. And again, this is getting back to the efficacy consideration, unlikely to get their A1C to goal strictly on a single agent, on one of those two agents, and therefore likely combination therapy. And I would say, what combination would one use? Well, I think it's a little bit dependent on the patient, and so we very much believe in shared decision making, and the conversation with the patient would be something you're all familiar with. We have these two medications that can lower your risk of another heart attack. One is injectable, but will lead to significantly more weight loss. The other is a tablet that will also give you benefit, but not have that significant weight loss. And again, I'm surprised at the number of individuals that will pick injectable therapy when it comes to weight loss. For those of you that are as old as I am and remember when Exubra was available on the market, and inhaled insulin, the first version of that, became available. Um, it never really caught on, and it was in part there were obviously safety concerns, but the thinking in those days was the big barrier to insulin was injection. And now in this class of drugs, a GLP-1, we see many patients willing to take injection therapy. And I think it's taught us all that the barriers to insulin were probably not as much around injection as a number of other factors, sense of failure on the part of the patient, the threatening that, primary care people often said, if you don't do the right thing, you're going to end up on insulin, and a lot of misconceptions on insulin. So sorry, digress there, but I think we see sort of the rationale here for combination therapy early in this individual. Uh, this for house staff and fellows is a great reference table that I'd encourage you to have ready access to. It describes each of the agents and really in one table, sort of efficacy, side effects, considerations, and a wonderful reference source. And as you have house staff rotating on your service, a great opportunity for them and medical students to learn about these different medications. Okay, so that was around individualized treatment, pharmacological treatment for type 2 diabetes. And let me also make the obvious statement here is that all of these individuals are recommended to have lifestyle and behavior change therapy, and that is not new, and therefore I'm not highlighting it here, but in no way does that diminish how important that is. So the other thing that was new this year in terms of individualized care was really around type 1 diabetes. And we've really not had these kinds of specific recommendations around the management, pharmacological management of type 1 diabetes in the past. And this really derived from this consensus report that I encourage you to take a look at if you've not seen it, by ADA and EASD, that talks about type 1 diabetes. It's really very well referenced and evidence-based and has a lot of wonderful information in it. And so I'll just share 2 or 3 things from that. One is this table to guide clinicians in how to individualize insulin regimens for people with type 1 diabetes. And again, whereas I talked about 5 different areas that one would think about for people with type 2 diabetes, here we really have 3 considerations and the different regimens rated according to those 3 considerations. First being around flexibility of therapy, hypoglycemia, and then cost. And in the first case, it's what you're most commonly used to in sort of basal bolus therapy with a long-acting analog and rapid-acting analogs with meals, and moves on down to fixed premixed insulin with lower cost, but more hypoglycemia risk and less flexibility. And similarly, the same kind of information for, as you were talking about earlier, automated insulin delivery, and the sort of 2 flavors of that here, and then finally the third being pump therapy without automated insulin delivery. And again, hypoglycemia and cost are really the considerations here in terms of the differences. Um, Again, these are good reference tables, not expecting you to read this slide, but just to alert you to find this within the standards, again, particularly for house staff. And it describes each of those regimens that I just showed you, and gives you starting doses and pros and cons, and flushes out that table a bit more, and a great reference tool for individuals. Uh, Finally, the last individualized treatment for type 1 diabetes is around transplantation, and that's an area where we obviously are anticipating rapid increase over time, and essentially divides the fork here is around whether individuals have significant chronic kidney disease or not. If they have significant chronic kidney disease, if it's a living donor, kidney transplant, and then whatever the insulin transplantation, whether pancreas, islet, or beta cell transplant, following the kidney transplant. For a living donor, a non-living donor can be simultaneous. And these are the criteria for transplantation for individuals without end-stage renal disease. Essentially, it is people that have failed medical therapy. I think fortunately now with automated insulin delivery and a lot of the tools that we have, this is much a less common a need for transplantation for those without without this without kidney failure. Okay. So we are about halfway in. This is a few blocks from where I am here in Boston. Today is actually the Boston Marathon just outside my window. And so you can see the security is out there and all of that kind of stuff. This is the Boston Public Gardens for those of you that have been in Boston in the past. So halfway through, we've talked about screening. We talked about individualized care. I'm now going to talk about comorbidities as the third big area and some new things here. This diagram that I think you'll see shown in a lot of different places, again, targeted more towards primary care, but it's to give this holistic view of the prevention of complications of diabetes at the top. And all of this is on a foundation of lifestyle management. And then 4 pillars to consider. And the first, glycemic management. And, that's what everybody thinks about when they think about diabetes. But what we wanted to do here is really alert clinicians to the importance of the other 3. And that is, of course, blood pressure management, lipid management, and then in the third case, drugs that can protect cardiovascular risk and renal risk, and again, specifically around the GLP1 and SGLT2. So what else is new in this section? The evidence and recommendation for use of both GLP1 and SGLT2 drugs together that are effective in reducing morbidity and mortality in those with atherosclerotic cardiovascular disease. There also is a reminder around where people are in their journey of diabetes and the aggressiveness of therapy and goals. Early in the course of diabetes, more aggressive A1C, lower, even as low as 6.5. And as many of you are familiar, there's a legacy effect. There's studies that show that glycemic control in that first year after diagnosis is predictive of mortality a number of years later. And so early treatment and early aggressive treatment is really important. And on the flip side, further advanced disease with multiple complications, glycemic goals may be higher, 7.5, sometimes as high as 8, but really important considerations about cardiovascular risk being a dominant part of management of these individuals. The other thing that was new this year is for those that are longstanding readers of the standards of care, we used to have a chapter that was all microvascular complications together. There's so much happening in the kidney field that we broke out chronic kidney disease as a separate section. And so you'll see this chapter, and there are a few new things here. The first is for the first time, there is a recommendation and a goal for the reduction of albuminuria to reduce that at least by 1/3. And again, this is, many of these things are targeting our primary care colleagues, where you know that 90% of people with diabetes get their care. They need to consider albuminuria and target lowering it by at least 30%. In addition, there are recommendations about the addition of finerenone therapy to prevent progression of CKD. And then finally, that it is important to measure both albuminuria and EGFR and follow those values in people with CKD. Again, something that many of our primary care colleagues are less familiar with and therefore important to highlight. In terms of other comorbidities, there's discussion around COVID vaccination. And again, the recommendations are aligning with the CDC since that's a rapidly evolving area. There is an expanded section on NASH and NAFLD, non-alcoholic fatty liver disease, recommendations around screening individuals, description of the evidence for therapy beyond lifestyle, which of course is very important, weight loss very important, but pioglitazone, for example, shown to have efficacy, GLP1 agonists, some of them have been shown to have efficacy, SGLT2 preliminary studies also showing efficacy. And I think this is an area that over the next year or two, I think will really be expanded considerably as there are a number of drugs that are in the pipeline for treatment of what is, largely diabetes is becoming the leading cause of liver disease and requires attention. The other comorbidity that is highlighted is cognitive impairment, and diabetes increases the risk of cognitive impairment. Frequent hypoglycemia also appears to increase that risk, but you can see that increased risk in the absence of hypoglycemia as well. That one needs to screen for cognitive impairment because it is not uncommon, and then think about how to adjust therapy and reduce complexity of therapy based on that. Okay, so I think we're going to be good on time to have questions because I see some interesting things in the chat. So I look forward to diving into that. We will hit the last of the sections. We talked about screening, new recommendations, individualized care, both type 2 and type 1. Comorbidities we just talked about, and then finally glycemic assessment and technology. And this is a section where your very own Diana Isaac helped enormously in putting this together. So in terms of glycemic targets, for those that are less familiar with this concept of time in range, here are the parameters of what we look for. It's not just about A1C anymore. And again, intuitively, for those, again, that are less familiar with this, you can have an A1C of 7 with glucose values that vary, just very little, or an A1C of 7 where glucose values vary quite a lot, and there's very little time in range, and obviously not good for patients because of the hypoglycemia. And so you can see the recommended targets for the different buckets of time in range here. Other recommendations are really, and this I think we all experienced during the pandemic, if it were not for the availability of CGM for many of our patients who are not able to get A1C values, really using CGM data to make therapeutic adjustments, and that ideally a 14-day measure is a reasonable and acceptable time range to be able to use to make medication adjustment. We remove the self-monitoring blood glucose concept and really talk about blood glucose monitoring as the correct language and more accurate language to use. And then finally, that CGM data should be used to change medical therapy. Uh, we then go on in this section to provide the evidence for time and range correlating with the risk of microvascular complications. As you know, there's been debate about that. The evidence is there, and therefore it's an acceptable measure along with A1C as a target to manage individuals with diabetes. And then a call out to hypoglycemia, that when one is looking at the different times in range, the hypoglycemic range is really the first thing to target. Individuals that have hypoglycemia need to have some way of addressing that, either through education, understand what caused it, or actual change in therapy to reduce hypoglycemia, because at this point, there are more individuals going to the emergency department for hypoglycemia than hyperglycemia. And so something we obviously need to do better on. In terms of technology, really excellent section, highly well referenced. And again, for those of you that follow this closely, I encourage you, because it really is a beautiful accumulation of the data and evidence to date. And so first of all, the choice of CGM is really based on a conversation with the patient and individualized. That this is as much as anything a nod to our payer colleagues to say blood glucose monitoring still needs to be available for individuals on CGM, whether that is for some of the CGMs that require calibration or validation of outlying glucose or glucose that's changing rapidly, or just running out of their CGM. And so I've had patients that I expect you have as well, that they had a problem with their CGM. They had used an extra one. They couldn't get more right away, and they didn't have any blood glucose monitoring available to them. So we want to alert people and payers to cover this despite being on CGM. Um, the recommendations for use of real-time or intermittent blood glucose monitoring, the broad recommendations are the same, and that's in that second bullet. But what we do very carefully is parse out the evidence supporting each of the devices for each of the indications. And so for those of you that are interested in the specific evidence, you'll see the study cited. But I think the take-home message is this really strong statement that either form of continuous glucose monitoring is really recommended for all individuals, in essence, on insulin, whether they have type 1 or type 2 diabetes, whether they are young, whether they are adults, or whether they are older adults. And that evidence is very strong for multi-dose insulin and insulin pumps, but it also is there in RCTs for basal insulin, and that's where we are working with the payer community, and particularly CMS, to ultimately get coverage for those on basal insulin, because that has not been covered as well. I'm going to move on next, and here the recommendations, again, we're very cognizant that the standards of care are used by payers for coverage decisions. And so particularly here in the US, Medicaid state by state varies in terms of their coverage of insulin pens. Want to make it very clear that insulin pens are the preferred way to inject insulin, unless, of course, the patient or the caregiver prefers syringe and vial. And then finally, around technology and diabetes and digital health solutions, they've really exploded over the last 3 to 5 years. And now a number of them have RCT data and even more have pre-post data showing benefit for individuals. And so there's a recommendation that these can be useful in the management of diabetes. And I think particularly again during the pandemic, and I'll be curious in the Q&A, how much of your patient care is still virtual versus all on site. These between visit tools have really been very effective in helping individuals manage their diabetes with real time and guidance. So I covered a lot in a short time. I highlighted those 4 areas that were new in terms of screening, 18 risk factors, 35 everybody, the individualized care, both for type 2 and type 1, and the different considerations for type 2. Again, comorbidity being one side of the algorithm and dictating a lot of what should be chosen. Then we talked about individualized care for type 1 diabetes, comorbidities, and particularly new information around CKD, and then finally technology. But of course, in the short time that I had, could not cover everything that is there. And so let me alert you to some wonderful resources. This has been an area that the ADA has really been focused on. How do we translate this wonderful document into more action and be able to improve care? One of the efforts that some of you actually have been involved with, and thank you for your contributions, a program called Overcoming Therapeutic Inertia. And that has been an effort to deal with the observation that despite all of the new therapy and everything that's happened in the last decade in diabetes, A1C has not really changed nationally much at all. And so we believe a large part of that is this concept of therapeutic inertia, where an individual presents outside of goal, and there's no change in therapy that occurs at that visit. And of course, there are many reasons for that. There are patient factors, there are provider factors, there are system factors and practice factors. And again, the effort is aimed at addressing all of those. Um, that was a little digression. Let me get back to the standards of care and different resources. So the idea is how do we take the standards and make them more actionable? And so first, we have an abridged version that was alluded to at the beginning that is shorter to be able to look at. There also is a free app, and I really encourage you to download it. I have to say, I sat where you were not that long ago when I was at Joslin, and I often didn't download that app. And then, of course, here I did, and I found it hugely valuable. I refer to it quite a lot. The whole standards are there. You can look things up quickly. It's interactive. It really, a lot of the big figures that I showed you are available there, and it's a nice thing to be able to check literally when you're seeing a patient. In the office or virtually. There are also pocket cards and a webcast available. And we're developing a number of infographics as well that we'll be using to help other clinicians be able to adopt the changes and what's present in the standards of care. So with that, I very much hope that I will see many, if not all of you in New Orleans in a matter of a few weeks. Uh, Early registration ends the 21st, just in a few days. So if you want to get a break on the cost. Please register. It's been a long time now that we haven't all seen each other in person, and we'll be taking appropriate safety measures, but we're really excited for an incredible meeting that brings clinicians from around the world to talk about the latest science and research in diabetes. So again, hope to see you there. Sorry that I could not be there to join you in person, but look forward to do that some other time. And I will unshare my screen, and then I'll be glad to answer any questions that you have. So let me see, how do I?
Thank you so much, Dr. Gabbay. That was a wonderful presentation. I think it's going to get a lot of views when it goes on our EMI live playlist on the Cleveland Clinic YouTube channel.
Oh,
Just
great.
how well you have summarized this. I'm sure our family medicine and internal medicine colleagues who could not join today would be very eager to listen to this presentation and not go through the full version of the guidelines if they
Yes, yes. Well, and in fact, I am going to have the opportunity to present this to some of the medical folks and medical grand rounds later this week. So,
Absolutely.
but yes, I'm glad that you will have this taped. And do I control taking my slides off, or do you do that?
You can just keep it on. That's okay. While you're
Oh,
answering questions, that's fine.
or I think I found how to stop sharing.
Okay, perfect.
Yep.
Thank you.
That way I can see people foreseeable.
The Cleveland Clinic Endocrinology and Metabolism Institute is actually, we are spearheading and working with primary care to develop interventions where we can increase the use of the newer diabetes medications and practical interventions, things that work with patient information, that work with electronic medical records. So we're very cognizant of the fact that primary care needs this help because of their paucity of time and, the paperwork that keeps on flowing in all our offices. So commenting on the paperwork part, the big change from last year to this year was that metformin was no longer essential first line, and it said probably includes metformin. But insurance companies don't seem to have necessarily followed that, and we are still getting paperwork. So how is the ADA trying to push that through?
Yeah, no, thanks for that question. And I'll also point out that, one of the reasons I would have liked to be there in person is to meet with various people, because I think Cleveland Clinic is really one of the great institutions that have done a lot of work in engaging primary care and done a lot of innovation around that. So uh, um, so, I think one of the areas that ADA is very active in, and particularly over the last couple of years, I think has really stepped up its interactions, is around advocacy, and specifically working with CMS. We engage with a number of the commercial payers, but really most of our time is probably, to be fair, spent with CMS, because what they decide often trickles to other organizations and other payers. So we have been in discussions with them about reducing the burden of paperwork and prior authorizations, as you allude to. We haven't gotten there yet. The other observation when I speak to some of the commercial payers is the typical pattern for removing prior authorizations is often standards of care state something. That's step one. They seeing providers asking for those things, and going through the unfortunate paperwork. And then ultimately, when that volume reaches some, I don't know, magic number, they sort of go, yeah, okay, the evidence does support that. And there's a significant demand. So our hope is that in the not too distant future, that will loosen up as as well as CGM availability. In fact, if you don't mind me digressing just one moment, we have a project in Columbus, not so far from you in Ohio, around health equity and expansion of CGM use. And so we've been working in underserved populations, primarily the African American community, to expand access. And Medicaid is now willing to expand their access in the state of Ohio to use of CGM, and that's another victory that we're very happy about, and hopefully will be permanent.
Thank you. I think the clinic is also working with Medicaid providers to work with diabetes education to increase their patients who get that for overall better diabetes control. Moving on to telemedicine, since you asked about telemedicine at the clinic, I would like to comment that because of I think the vision of the enterprise leadership as well as the institute leadership, we are at about 40% for telemedicine in our clinics, and we were 100% for 3 months at the beginning of the pandemic. So we were able to switch very quickly to telemedicine so that the diabetes care for our patients was uninterrupted. But Dr. Feynman is asking, and we would definitely like to know as to as your comments on the use and need for telemedicine and diabetes management.
Yeah, that's a great question. So I similarly, I was CMO at Joslin when the pandemic started and went through the fire drill that I expect you all did in a matter of a couple of weeks, going from 25,000 patients in-house to all virtual. I've been surprised now that we are. I still see patients at Joslin. Now that it has gone mostly in person. Even when we were in the hybrid phase, many patients themselves preferred to come in and see their provider. And that was a little surprising because I felt in some ways virtual worked just as well and was more convenient. So I think that the difference of in person, beyond obviously physical exam, is a piece of care that we sometimes underestimate for our patients, and that's the relationship. Um, you know, Part of what helps us encourage, engage, and guide our patients in behavior change and adoption of new therapies is really the trusted relationship we create with them. And although that can be done virtually, I think it's more powerful in person. So I suspect in most cases, some hybrid method is probably ideal. But honestly, I think it's also patient driven. For some patients, this works just as well. And um, I think it should be a patient centered decision.
Thank you, Dr. Gabbay. I'm going to take now people with raised hands, starting with Dr. Adi Mehta. Please unmute yourself.
Thank you, sir. That was an absolutely superb and wonderful, concise presentation, and I congratulate you on that. I also congratulate you on your ability to put virtual visits into a proper place, which I think at my age is probably older than you. However, I do have a problem. You, in the overall document and in your presentation, did something that we don't seem to realize we do. You concentrate on the left side of the graph. You concentrate on those people. 70% of the people with new onset diabetes are on the right side of the graph. And the problem is that there is no hierarchy. For the first time, one guideline talked about a hierarchical approach using pathophysiology of the disease, and that was the DCRM. I don't always remember these alphabet soups, but they did talk about hierarchical. And in the ADA guideline, by the way, the ADA guideline is the global guideline. Every country in the world and their dog takes the ADA guideline as the basis for their guidelines. It is very important that we start to consider the pathophysiology of the disease on the right side and give a hierarchical. DeFranco has studied for a long time. Now Yehuda's team is saying the same thing. And the ADA must come up with a hierarchical way to treat diabetes when they don't have the complications.
It's a fair comment, and I appreciate that. So first, I'll say that focus, from this talk was really about what's new, and so the left side is really about what's new, and that's why I emphasizing that. That said, we struggle with how to create a evidence-based hierarchy beyond the sort of effort that ADA has been very engaged in leading around precision medicine. So we envision a time where we'll be really quite able to identify the different pathophysiological phenotypes that, as you know, have been categorized in different ways to choose therapy. Um, I think our hope, at least at this point, is that it is a conversation with the patient looking at those other factors, because for any given one might be the dominant, and the unfortunate one is cost and access sometimes really decides everything, which we wish it weren't. But you make an important point. Thanks for sharing that.
But you're saying you go with the science. The fact of the matter is the pathophysiology is relatively well established. There is the progressive part of the disease is the beta cell failure. And if we don't address beta cell failure away from all that those medications can do in other areas, if we don't address beta cell failure, we're continuing to allow the disease to progress. So I think we need to put an emphasis on that in spite of cost. We have to put an emphasis on that and try and put a perspective that this is the hierarchy that you need. That's just a comment. But
Yep. No, I hear you. And I think that's important, and the evidence to preserve beta cell is, somewhat there. At the same time, as long as we're talking about controversies, you're probably all familiar with the nice article that came out in Lancet saying, really, it should all be about weight loss, that 15% weight loss should be the target. And that should really drive therapy, because everything else gets better. And so I know we won't have time to debate that, but I'll tell you, as we're looking at the professional practice committee is discussing the next generation, next year's standards, that's an area of hot debate.
Thank you. Dr. Khan, you are next. Please unmute yourself.
Hi, Dr. Gabbay. I just wanted to say thank you.
Oh, so nice to see you.
And for all your mentorship. Many people don't know what an amazing mentor you are, and I just wanted to thank you for introducing me to the field about 15 years ago. So time goes fast.
You were a star then and a star now, and thank you. Yes, it's great to see you.
I would like to add, Dr. Khan is now the medical director of the Cleveland Clinic Bone Center of Excellence. And she was the one who came to us and said, you have to invite Dr. Gabbay, he's the best. So we have to thank her for the invitation. And then we have Dr. Bergera next, our EMI Institute chair, who we have to thank why we are all working 2 days from home in our track pants. Dr. Bergera.
Thank you, Dr. Gabbay. This was a great presentation. We are very proud of our institute working closely with the ADA. And I was very happy to hear what you said because of weight loss. And that was going to be my question. Over the years, the ADA was a little bit reluctant about talking about obesity and the role that obesity plays in the etiopathogenesis of type 2 diabetes. And I was wondering to what degree you see that in the future, does that effort around obesity and even anti-obesity medications that we have right now, and they are very, very effective, some of them, as you know, could be playing a role in the algorithm of treatment of type 2 diabetes.
Yeah, absolutely. Very important. I think will become more important, and particularly as as many of you are aware, the dual cretins, GLP1, GIP dual agonists, Tirzepatide is the furthest one along, may be available. I encourage you at our scientific sessions, which will also be available virtually. We just met with our European colleagues, ADA and EASD. We're putting together a management of hyperglycemia paper, an update from what had been present in the past, and that's something that the draft will be presented for comment at the scientific session, and that'll be an opportunity for people to weigh in. And this area is certainly addressed.
Thank you.
Thank you. I'm going to move on to further questions in the chat. Dr. Feynman is asking any suggestions for diabetes management during the month of Ramadan, which is actually going on now, or in other religious fasting.
Yes. So there are a couple of really nice papers that summarize this data, and on our website we have some information as well. I always find fascinating that many individuals during Ramadan often gain weight. Whereas you might think that they would lose weight if you're uninitiated, and so yeah, I think it's both prevention of hypoglycemia, which is sort of the obvious, but also consideration about potential weight gain that occurs in some individuals.
Thank you. Another question is advice as to the need or use of glucagon in hypoglycemic urgency/emergency.
Yeah, an area that's close to my heart. I speaking of mentorship, I had a Harvard medical student that did a project with me, and we published in the Annals of Internal Medicine, that looked at the availability of glucagon for emergency personnel in the U.S. And it's pretty bad. Like to me, it seems that should be part of any emergency response to individuals where they have hypoglycemia. The other data is that if you look at individuals that have been to the emergency department with a hypoglycemic episode, and you follow them to see if they have a prescription for glucagon, only about 5 or 10% do. And so I think there's a huge opportunity there to make glucagon available.
Thank you, Dr. Gabbay. If we have no more questions in the chat, we are a little bit over time. I would like to add here that some of these concepts about weight loss and diabetes, the pathophysiology, in fact, the glucagon part might be covered at the Cleveland Clinic Diabetes Day that's coming up on May 5th. So we are hoping that a lot of our department and primary care will join in for the latest updates there as well. Thank you again, Dr. Gabbay. That was absolutely great. And what I'm hoping is that we will see you in person sometime soon. For those of us who are on, our next CMI Live is going to be July 18th, and we have Dr. Paul Ledinson coming from Johns Hopkins School of Medicine. All of you have a wonderful day, and we will see you next week. Thank you again.
Thank you, everyone.